Hello, my name is Jose Maria Abadal, vascular and interventional radiologist from Madrid, and I would like to welcome you to the hands-on device training on microwave ablation.
Hi. My name is Dimitrios Philippiades, vascular and interventional radiologist from Athens. Well, we are really their avatars created with artificial intelligence. You will meet the real ones soon. Meanwhile, we are the AI coordinators that are going to guide you through general aspects of microwave tumor ablation.
Okay, let me cut to the chase. Do you know the difference between radiofrequency and microwave ablation? Radiofrequency ablation creates heat through ionic agitation of water molecules. Current is delivered based on tissue impedance. In RF, there is closed-loop circuit made by RF generator, needle and ground pads. An alternating electric field is flowing within the tissue of the patient. Tumor particles around the tip get electrically charged and begin moving with each other. In microwave tumor ablation, we use electromagnetic waves to heat and destroy cancerous tissue. Microwave ablation creates heat through friction of water molecules spinning against each other. In microwave, there is no current flow through patient. The antenna emits the energy. No pads. You could even use it in patients with pacemakers. By the way, an interesting fact is that we should not use the word antenna when speaking about microwave. We should instead use the word probe. To be classified as antenna, the device must transmit or receive energy in the far field like satellite or cell phone antennas. Microwave ablation probes do not fit this definition because they operate in the near field, very close to the device. So, probe would be the word.
Okay, here is some basic stuff about energy you must try to understand. Heat efficacy is defined as the difference between the amount of heat produced and the amount of heat lost. Therefore, effective ablation can be achieved by optimizing heat production and minimizing heat loss within the area to be ablated. The relationship between these factors has been characterized as the bioheat equation. In consequence, one has to keep in mind that in clinical practice, so the coagulation of a tumor will depend on heat production that is correlated with the intensity and duration of the energy deposited, and that is something definable. Our goal is cell death, and that means 100 degrees, or can also be achieved with temperatures above 50 degrees maintained above 4 to 6 minutes. On the other hand, we will have a tissue interaction that is variable and heat loss, for example by nearby vessels, that it is unpredictable. In microwave, the energy will depend on the wavelength, and tissue interaction will depend on the dielectric properties. Ablation probes do not benefit from an unchanging environment. They are in constant and intimate contact with the dynamics of tissue. Let us understand this with a fortnight example. Our warrior has different weapons, wavelengths, depending on the enemy, different tumors, and state of the shield of the enemy during the fight, changing composition during ablation. So wavelength is key player in shaping electromagnetic fields, winning battles, creating a controlled heat volume. But let us be practical. Frequency of the microwave is controlled by the device, and we only have to optimize the power and the time to achieve the desired in vivo or ex vivo volume of ablation.
Okay.
Here is some more basic stuff about energy you must try to understand, and it's important.
As we have seen, ionic agitation of water molecules causes tissue to heat rapidly and coagulate. We have got an active ablation zone. This brown zone is the region within the ablation zone where tissue coagulation is ensured. In this area, we are certain that the tumor is killed. And we have got a passive ablation zone. As the ablation zone grows, conductive heating creates this passive ablation zone.
This zone has the potential to contribute to the ablation zone, but is highly unpredictable and is heavily influenced by surrounding anatomy. So let us be critic. In this zone, we cannot guarantee that the tumor is going to be killed, and worst of all, we have heat that can damage unwanted delicate structures. Other basis concepts are thermal sink. That happens when blood flow from vessel draws heat from ablation zone and cools passive ablation zone. And finally, the oven effect. Within encapsulated tumors, the passive zone can easily extend to the tumor boundary. Microwave energy creates increased heat within the active zone, which in turn creates larger passive ablation zones. This is what we demand on new ablation devices. Precision in the active zone with a thin passive zone. almost and of course, no thermal sink effect. And predictable spherical ablations, this will compensate different tumor morphology and our technical imprecision. Because, it will be always easier to surround a tumor with a sphere than with a pair. Don't you think? So here we have got a nice comparison chart between radiofrequency, microwave and irreversible electroporation. Oops! I missed cryoablation, that uses cold. Anyway, let me highlight the basics. Practical pros of microwave over radiofrequency. In microwave we obtain a more predictable ablation zone, almost spherical, larger, in less time and less susceptible on tumoral tissue properties o adjacent vessels. These are the most frequent indications for microwave. Primary liver tumors or metastasis, kidney tumors, lung tumors and bone tumors. And even thyroid nodules and breast tumors.
Although it is beyond the scope of this introduction, let me use this meta-analysis of hepatocellular carcinoma to highlight the state-of-the-art of microwave. The study is comparing microwave ablation in metastasis and HCC versus liver resection, and conclusions are: microwave can be an effective and safe alternative to liver resection in patients with tumors that are not as amenable to resection. Survival and recurrence outcomes were either not statistically significant between microwave and liver resection. Microwave exhibited significantly shorter length of stay and operative time, less intraoperative blood loss, and fewer complications. But don't let us get too high with microwave ablation. We have got 5 problems with thermal ablation. 1. Near big blood vessels, we lose energy and we may not kill completely the tumor. 2. Heterogeneity on the energy deposition depending on the tumor histology. That happens more with radiofrequency. 3. Shape. Sometimes we don't create perfect spherical ablation. 4. Heat. We have undesired heat responsible of complications. And 5. Finally, there is lack of standardization of the procedure. Energy protocols, different devices, and needles, using ex vivo ablation charts. Here is a case of connective cooling on both sides of a kidney tumor because of surrounding vessels. This causes incomplete ablation or recurrence, depending on the time of the control. So, the Achilles heel of ablation is recurrence. Residual unablated tumor or local progression is the same for the patient. He still has tumor. For us, depending on the timing of the imaging follow-up, we will classify it as unaborted tumor or local progression. And this happens in up to 11% of the ablations. That is why we have to be very straight with patients and inform them before ablation that tumor may not totally be cured, but if this happens we are able to retreat. And that conventional surgery will always be an option. Here is my vision of the 4 main causes of recurrence: our technique, the device chosen, the cellular type and the size of the tumor. But probably the main cause of recurrence is us. Targeting lesions is physician dependent. If we don't target the lesion with precision, we will have incomplete ablations. Here expertise and training matters, and now navigation systems may shorten the learning curve and standardize the procedure. Adjacent structures like vessels, as we have seen, are also responsible of sink effect and thus live tumor nearby blood vessels. An oncologic margin is mandatory. In most probes it will be the distance between the tip of the probe and the ablation margin. That is why we normally position the tip at the deepest part of the tumor margin. Always try at least a 1 cm margin. Recurrence will appear if we did not give sufficient oncological margin or were not very precise with overlapping ablations. Or maybe we are not using the best ultrasound for ablation. Never accept the ultrasound leftovers from the radiology department. Always with the best ultrasounds. Sometimes technology may be responsible for recurrences. It is well documented that despite a well-done RFA treatment, skip islands of viable renal cell carcinoma cells may still remain within the treated tumor. May some probes or technology cause more recurrences? And how about size? Expect incomplete ablation with large tumors. Here you have got literature example of T1b renal tumor. More recurrences and more complications. Here my case. A 45 mm renal tumor on CT. 2 probes were used, both with pullback. Looks great, the immediate control. But follow-up at 3 months shows incomplete ablation, typically in the hilar contour of the lesion, where big vessels exist. So after a second procedure with 2 needles we finally achieved a complete tumor response.
All that glitters is not gold. That means that our super minimally invasive surgery also has potential complications. Here you can see an extensive chart with complications, fortunately infrequent. Bleeding and infection most feared. Most complications caused by me and my needle. Should we invest more time in the pre-procedure? Should we use prophylactic antibiotics in our ablations? Should we use coaxials? Should we adjust more precisely medications? Here you can see some technical tips. Probably the most important is the use of hydrodissection. But spend 1 second to read them all. But always consider microwave ablations as surgical interventions. Be at the multidisciplinary committee. Mandatory that the patient is referred to your IR consultation. It's the place to explain the procedure to the patient, give the informed consent, check with an ultrasound the visibility and access to the lesion. Avoid non-prepared ultrasound rooms, instead use operating room. Manage conscious sedation or much better, have an anesthesiologist. Consider antibiotic prophylaxis. Be prepared to handle complications. During follow-up, remember that the first CT or MRI are performed to rule out complications. At least you need 3 months to assess the efficacy of your ablation.
So, to summarize, ablation technology has changed through all these years. We now have clinical studies with long-term follow-up. Low recurrence and complication rates have been demonstrated. And if we compare ablation to surgery, they are equally effective, with the advantages that with ablation we have less complications, we preserve the organ and we do not exclude a future surgery if needed. We are now in the 3rd generation of ablation devices. With predictable spherical ablations in different histology, with less heat sink effect and with plug-and-play interfaces of easy use.
But not all devices are the same. In this hands-on training with the industry you'll have the chance to discover it.